Thank you so much about this information. The main source is from this information we have teamwork. This is most important in this advice about this introduction. We sorry about sharing just video recorded because of different time, and we have especially thanks to Dr. Firas Khalifa Alnidawi, consultant neurologist, Townsville University Hospital, graduated from Baghdad Medical College in 2002, fellow of Iraqi Board in Neurology 2012, fellow of European Neurology Board 2016, master in stroke 2020, Daru University of Krems, Austria, postgraduate diploma in swallowing disorders 2021, University of Barcelona. Clinical lecturer, Arab Gulf University, Bahrain 2015 to 2018. Clinical lecturer, Royal College of Surgeons, Ireland and Bahrain, 2019 to 2022. Research experience about Dr. Firas participated in many international and regional stroke research paper. Reported the first carcel case in Arabic population, 2021 and 2022. Won the first prize for MENA Stroke Congress poster. Participate as a speaker in many regional stroke meetings. As we mentioned, we have third part question and answer arranged by Dr. Bara from at Diwania Teaching Hospital.
Thank you, Dr. Mustafa. Welcome all. I'm Bara, a junior doctor in the second year and have an interest in neurology. I'm very pleased and honored to be a part of this society. For today, we would be more than happy if you could write down your questions in the chat box, as we are going to answer them at the end of the session. Sorry. Thank you.
السلام عليكم ورحمة الله وبركاته.
تمام الصوت
I
تمام.
want to
تمام الصوت.
thanks the organizer and generally and specifically to the Iraqi Stroke Network for their kind invitation to have this talk. So today we will discuss a new era in ischemic stroke treatment. To start with, these are the outlines of the presentation, which will be divided into two chapters. The first is expanding the indications of thrombolysis, and the second will be the current advances in endovascular treatment. Stroke is the second leading cause of death worldwide, and according to the Global Stroke Fact Sheet published in 2022 by the World Stroke Organization, annually we have around 12 million new stroke, and 1 out of 4 people over the age of 25 will have stroke in their life. Worldwide, out of 100,000, annually there will be around 99% develop stroke. And just in the region, in the Middle East region, we have in Bahrain, we have around 110 out of 100,000 annually will get stroke. While in Iraq, despite the lack of data, but I found this paper published in Frontier Neurology, and it points that the incidence and prevalence of stroke in Iraq is higher than other countries in the Middle East. We know that stroke treatment, the first time that we have acute treatment for acute stroke was in 1995. Initially, we had the NINSE trial, which was a multi-center trial. And in this trial, the investigator found that giving alteplase will result in a better outcome than the usual medical care. And we spent around 13 years until we expand the window of TPA from 3 hours to 4.5 hours. And we know that we have the strong recommendation from the American Association of Stroke Association that alteplase within 4.5 hours indicated as acute treatment of stroke with a level of evidence 1A and 1B if we extend the window for 4.5 hours. A meta-analysis of the studies of alteplase show that alteplase effectiveness is time dependent. So as we are giving the alteplase earlier, the benefit will be higher. So if we give alteplase within the first 90 minutes, the number need to treat will be 4 to 5 to get a 1 good outcome. While if we delay the treatment until 270 minutes, the number need to treat will be 14 patients to get 1 good outcome. So despite this development, we stuck with strokes of unknown time. And as a neurologist, we face many times patient developed the symptoms without any witness and he's having aphasia. So we don't know when was the symptoms occur. And we face also those patients who wake up with stroke. And also we have patients presented beyond, and this is the usual scenario, presented beyond the 4.5 hours. So from here, we start the first part of our talk, expanding the indications of thrombolysis. So when the time window is unknown, we can use tissue window instead. And here we have two concepts. The first concept, using imaging as a biomarker of lesion age and reversibility. And the second concept, using imaging to identify the salvageable tissue, what we call them the penumbral images. To start with, we have using image as a biomarker of lesion age and reversibility. And this was applied in the recently published study, which is the Wake Up trial. So initially, the team investigator of the pre-flare study, they tried to apply this concept, but just let us know that the percentage of wake-up stroke range from 14% reaching to 30% of stroke. So approximately we have 20% of our stroke patients, they are woke up with their weakness, and 36% of those patients are eligible for thrombolysis, but we are excluding them previously because of time window. But because as you remember in the medical school, the teaching was if the patient wake up with stroke, you calculate the time window from the time he went to sleep. So most of the patient, you will exclude them from thrombolysis. So in a pre-flare study, the team tried to use the concept of using the image to identify the age of the lesion. So they took patients with well-known time and they did for them MRI sequences, and they followed these sequences. And as we know that stroke appear earlier in diffusion weight image, and they will appear later in the other sequences of the MRI and generally and specifically flare. And the investigator found that the patients with acute ischemic lesion detected in diffusion weight, but not in flare, are likely to be within the time window of thrombolysis, and thrombolysis could be safe and effective. The same team take this concept and apply it clinically in wake-up stroke. So they divided patients in those patients with the lesion appear in diffusion weight, but not appear in flare. So this means the age of the stroke is less than 4.5 hours. And the second, where the lesion appear in both flare and diffusion weight, and they exclude them. And I just will leave you with a short video showing the result of this study. So after this trial release, the release of this trial result in 2018, there was an update in the American Heart Association and American Stroke Association guidelines, stating that you can give IV alteplase using the diffusion flare mismatch concept to patients who wake up with stroke, or you don't know, or onset of the time of stroke. The second concept is using image as a biomarker to identify the penumbra. I know from our medical school teaching that the penumbra is the tissue that you can save if free perfusion performed. From language perspective, the penumbra is this region. You know, it's almost, you can see, but it's still not black. And the umbra is the black region. And at the tissue level, we know that penumbra, to have penumbra, you have two features. There is loss of electrical function, but there is intact cell membrane. And this region usually, fundamentally, it's reversible if reperfusion achieved. So using this concept in image, we use what we call it CT perfusion or MRI perfusion. We give contrast and we follow the contrast by image as the contrast passes through the affected tissue. And we have specific measures like cerebral blood volume, cerebral blood flow, mean time to peak, mean transient time, and Tmax. So cerebral blood volume is the total volume of blood flow in a given volume of a brain. And usually the flow will be low in infarcted tissue. Cerebral blood flow is the blood flow through a given volume of brain per unit time. And the mean transient time is the average time taken for contrast flow through brain region. The CT perfusion, actually, it's increased the sensitivity and specificity of detecting stroke. So in the anterior circulation, the sensitivity reached to 82, and in the sensitivity reached to 82, and the specificity reached to 95%. In lacunar infarction, it's reached around 62, and in posterior circulation between 76 sensitivity and 93 specificity. So how we can define stroke and the penumbra? So in case of penumbra, you have delay or increase in Tmax or mean transient time, while the cerebral blood volume, either it's increased or it's normal. While the infarcted tissue, the mean transient time increase, while the cerebral blood volume decrease. Using these parameters and giving them